The broadcast is now starting. All attendees are in listen-only mode.
Well, hello everyone, and welcome to our Wednesday webinar. I am Guriz Barkan. I am the president of the American Society of Cytopathology, and I'm thrilled that we have a wonderful group of guests today, including our very special guest, Dr. Bonnie Mason. The topic will be diversity, equity, and inclusion in cytology and beyond. A conversation with Dr. Bonnie Mason. Dr. Mason is the Vice President of the Diversity and Inclusion at the Accreditation Council for the Graduate Medical Education. She has a history of work in the line of diversity, equity, and inclusion. Dr. Mason earned a bachelor's degree in chemistry from Howard University in Washington, D.C. Her Doctor of Medicine degree from Morehouse School of Medicine in Atlanta, Georgia. Her general surgery internship at the University of California, Los Angeles, and she completed her residency at Howard University Hospital in the Division of Orthopedic Surgery. She's the founder of Nth Dimensions. Nth Dimensions is a physician pathway program and curriculum which is aimed to decrease disparities in healthcare workplace by increasing the number of women and other represented minorities in competitive specialties. As a nationally recognized champion for diversity, Dr. Mason holds adjunct faculty appointments in the GME in orthopedic surgery, as well as nationally recognized champion for diversity. She has received several awards from her peers, Specialty Society, and physician associations nationwide, including the AAO's Diversity Award in 2015. We have here also to discuss her work in the field of the DEI at the time of when ASC has founded its own DEI committee, and we have members of our DEI committee here. We hope to learn from Dr. Mason and to use them to create a more diverse, equitable, and inclusive environment here at the ASC. Today here is Dr. Alarice Lowe. Dr. Lowe is the chair of our Diversity, Equity, and Inclusion Committee at the American Society of Cytopathology. She's an associate professor of pathology and the director of Circulating Tumor Cell Laboratory at Stanford University. We also have Dr. Natalie Banet. Dr. Banet is an assistant professor at the Warren Alpert Medical School of Brown University and a staff pathologist at Women's and Infants Hospital in Providence, Rhode Island. She has a fellowship training in gynecologic pathology and cytopathology and is also involved in education, mentorship, and online learning. We also have Dr. Cecilia Gimenez. Dr. Gimenez is the Director of Cytopathology Fellowship at Northwell Health and an assistant professor at the Zucker School of Medicine at Hofstra Northwell. She has fellowship training in surgical pathology and cytopathology. She's also involved with cytology education and has volunteered in underserved communities in developing countries. And last but not least, we have Dr. Evita Henderson-Jackson. She's an associate professor and pathology residency program director at the University of South Florida, Morsani College of Medicine in the Department of Pathology and Cell Biology. She's also an associate member of the anatomic pathology department at Moffitt Cancer Center in Tampa, Florida. She has fellowship training in oncologic surgery and cytopathology and is involved in medical education, graduate medical education, GME wellness, diversity, inclusion, and equity initiatives. This is a wonderful group, a wonderful panel, and I am so excited to hear all about this. Take it away, please.
Thank you so much, Dr. Barkan. Thank you for these kind introductions. And our session today will mark the start of our Diversity, Equity, and Inclusion, or DEI, talks for our society and hopefully beyond as well. Thanks to all of you for joining us. Today, we'll have a portion of this webinar to speak with Dr. Mason with our pre-planned questions, followed by a period of audience-provided questions and answers, hopefully, for you as well. So if there is a question you would like to ask, please put it in the chat function, and hopefully we'll get to as many of those as we can at the end of the talk. Now, before we start with Dr. Mason, we have a few polling questions for the audience. So you should see coming up on the screen, there's just two very basic ones. The first question for all of you is how much exposure have you had to DEI topics, so diversity, equity, and inclusion topics? So if you could please answer, I would really appreciate it. Great, thank you. I see some responses, and that means we have some attendees, which I'm very excited about. Thank you. All right. Great. And so now we have a pretty nice spread here. So some people have a lot, most people have some or a little, and some people have no exposure. So I'm so glad to have all of you here today. My next question for you is, do you have access to resources to support you in furthering diversity, equity, and inclusion in your areas of influence? And of course, this is a professional talk, but our areas of influence span beyond that. And so hopefully our support is not limited only to our professional environment, but I would like just to know how many of you feel empowered in this way. Great, I'm getting a lot of responses. Thank you so much. So it looks like a majority of people do, but close to 50-50 in here. So that is great. And in addressing that last polling question, I hope that over the course of this hour, you will realize that this topic is vast and none of us is an expert. But all of us on the committee, beyond the 4 of us representing the committee here today, are passionate about diversity, equity, and inclusion topics. And we want to enable everyone, including ourselves, to learn more. So if there are any questions that arise or aren't addressed in today's session, you can reach out to us through the general email box at the American Society of Cytopathology, asc@cytopathology.org. And so now I will hand the floor to Dr. Mason for some of her opening remarks. Thanks all for being here.
Thank you so much. I would like to just thank the American Society of Cytopathology for having me today and for inviting me to have a conversation with you about the topics that I discuss every day in my work as Vice President of Diversity, Equity, and Inclusion at the ACGME. I am really, really happy to be here, and I'd like to congratulate the steering committee of the DEI group here for ASC for endeavoring to do this work, which is not the easiest job in the world, especially if you're starting or we're starting from ground zero in a lot of specialties and subspecialties in medicine. So congratulations on taking the first few steps of a marathon that we are all on together. And as Dr. Lowe said, we're all learning. And this is going to be what we call a continuous learning and process improvement journey. And I invite everyone to take it with me and ASC. So however we can be of support from our office or our department at the ACGME, we're happy to do so. From this point, I think I just have a couple of slides that I was hoping to share with the group. Really just talking about the span of diversity that we have in pathology as a specialty, and then in cytopathology as a subspecialty. I was able to identify from our ACGME data guidebooks that are published every year on the ACGME's website. Anyone can go to our website at acgme.org and search for the annual data guidebooks and the aggregated demographic information about your specialty as data collected by race, ethnicity, gender, any number of permutations is available on that particular site. And so what we have here, and we'll see if we can get it into presentation mode. Great, wonderful. I just thought I would bring the data from the 2019-2020 academic year to demonstrate that out of all of the specialties in under the AC that are accredited under ACGME, when it comes to the representation of women, I mean, we have gender parity here. So really excited about the work that is being done in pathology with about 51.5% of the residents in pathology being women. If we move forward into the cytopathology demographics, we're able to look a little bit more specifically at cytopathology. And we can see here that in cytopathology, once again, we have parity. About half of our residents in cytopathology are male and half are female. We are also excited to have expanded our data collection categories to include the non-binary category, and those who choose to not report. We still offer that option as well. So when we're talking about diversity and collecting data, we want to make sure that we are presenting the opportunity for people to self-identify in ways that are not just traditional, but are inclusive. So this non-binary category, as well as the for those who choose not to report, having that category available in addition to male and female is very important. So, and then we can move, and I just brought one other table to show when it comes to our race and ethnicity data. Now we have subsets of data within our guidebooks that, I mean, I think they're well over a couple hundred pages per year for every for the individual specialties for you to review your data. But we're just looking at gender and race and ethnicity today. So if we're looking at our cytopathology row as a subspecialty, and then once again, you'll have the general specialties represented as well as subspecialties in the data guidebooks. You can see here that in cytopathology, so we have 43 of our residents who are white, 36 who identify as Asian, 5 who identify as Hispanic, Latino, or of Spanish origin, Black and African representation. So there are 3, 1 American Indian or Native Alaskan Native, and 1 Native Hawaiian or Pacific Islander as well. We have 15 who selected other and 21 who are unknown. Many of those unknown and sometimes others are people who choose to self-identify using more than one race or ethnic identifier. And so we are working with the AAMC and the AMA to come up with or to devise a data aggregation scheme that will include members who choose to identify with more than one race or ethnicity. And so basically that's what I have to present in terms of some of the overall numbers. And I know that we'll have some additional discussion around data points further in the talk today.
Great. Thank you, Dr. Mason. So now we'll hand it to Dr. Banet for our first question for you.
Dr. Mason, thank you so much for being here. It's a pleasure to speak with you. First, I would like to know more about you, we know your biographical information, where you went to school, where you got your degrees, but specifically, how did you move from an area like orthopedic surgery to working primarily now, I assume, in DEI work and diversity, equity, and inclusion? Yeah.
So that's a part of the story I don't often put in my bio, the transition and how that happened. But interestingly enough, as a chief resident in orthopedics, and this was before work duty hour restrictions were put in place. So just to give you a little bit of a timeline, I was actually diagnosed with rheumatoid arthritis as a chief resident. And I was only able to operate for about 3 years and practice non-operatively for another 2 years. But I'm kind of like Bo Jackson. So Bo Jackson couldn't sit on the sidelines after he gotten hurt. Remember, he had bilateral hip replacements, and he just couldn't watch football anymore. So it was hard for me to see patients, but not be able to get into the operating room. It's so early on in my career. But one thing I had always been passionate about, and it started going back to my medical school, which is Morehouse School of Medicine, historically Black medical school. And we didn't have a department of orthopedics. And at that point, even before I was even close to retiring, I was making my way back to Morehouse and worked with my gross anatomy professor, Dr. Wineski, and asked him if I could bring a tray of instrumentation to the first year class and to demonstrate a clinical correlation as to how their limb extremity content in gross anatomy correlated to the work that we were doing in the operating room, and actually we would walk the class through some simulated surgeries. And that early awareness program really sparked my interest into furthering that work in exposing students who may not have ever seen or met an orthopedic surgeon before, much less someone who was a woman, much less someone who was of color, to let them know that, you know, there are specialty fields out here that are available and accessible and inviting for them to make it more tangible as a potential specialty aspiration for them. So that began essentially the path that ultimately led to Nth Dimensions, which was the nonprofit that I founded just prior to retiring, recognizing I would need to transition into something out of clinical medicine, but still remaining in the field of orthopedics. So I describe myself as being a former connector of bones, having evolved into someone who connects people with resources, information, and networks to help them achieve their dreams and their goals. So that took a lot of time, support, a little therapy. There's nothing wrong with that in the transition into doing this work. And then subsequently, here I am 18 years later, having transitioned into the work at ACGME after just being boots on the ground, recruiting, and doing physician development and education in DEI over this time.
Yeah, I would say anecdotally, I would have loved to have had that experience of having an orthopedic surgeon in my anatomy lab. That sounds amazing. So
yes,
those students are very lucky.
They were always like screams and squeals of joy, and we'd have power tools. So made anatomy very exciting.
There were definitely no squeals of joy in my anatomy. Okay. Yeah.
Okay, Dr. Mason. Many of our members who are not marginalized or minority community or come from minority communities are here with us now listening. And given the events that occurred over the last spring and how you've been doing all of this work in DEI, does this last year feel different to you? And if so, how? And are you more hopeful now than before?
That's a pretty deep question, Dr. Henderson-Jackson. Thank you so much. I think, and I remain hopeful that because of the intensity of all of the events of the past year, and we're calling it or referencing this, 2020 into 2021 as a syndemic, both with COVID and then with the social justice work that we've all, at the very least, had a lot of awareness raised around, sparked by the death of Mr. Floyd. That was almost exactly a year ago. I think it just passed. I'm encouraged with the number of questions, inquiries that I've been receiving over this past year with people who are looking to engage in ways that they may or may not have been compelled to do before. So from that perspective, I am hopeful. But I also want to build in the expectation that, once again, this is a marathon, because the morbidity and mortality rates that were disproportionately felt by people of color in this country due to COVID, on top of the social justice issues with racial equity and inequities, these have been evolving over hundreds of years. And so the work to address, to educate, to acknowledge and accept, and thereby take requisite and meaningful action in order to create sustainable change is going to take time. That's not something that's going to happen overnight. So I think if we take a breath and then we take the next step, and then we are all honest about, number one, the challenging nature of these discussions around race, racism, the structured nature of both, and then the inequities and the disparities that that are resulting from our lack of understanding of diversity, which is ensuring that we have representation, that all are represented. So that's more of that quantifiable numbers approach to the work, right? So that's diversity. Equity, on the other hand, is the assurance of access. And I love Dr. Kamara Jones's definition of equity, which we work to adapt at the ACGME, is the assurance of that optimal work environment for all persons within said environment, such that such that everybody in that space can achieve their goals, can do the work that they are there to do. Why? Because they are all persons are valued equally, that historical references are recognized and rectified, and that we provide resources according to need for everyone in that workplace, in that work environment. So that's equity. And the resulting inclusion is what we want, is that environment where everyone feels psychologically safe. There's a sense of belongingness. People can be authentic to show up who they are, so that once again, they can achieve what they are there to do. So if it's, render equitable healthcare, teach residents. So if we're all showing up in the fullness of who we are, complete transparency and authenticity, then we can do that because we're now in an inclusive environment that is both diverse and equitable in its provision of resources, support, and value. So that's what we're looking for. And even just with that discussion, you can see that there's a lot that we can unpack and chit chat and talk about over time. And I think as long as we're willing to have conversations like this, that continues to spark my particular vantage point of being hopeful. And so I hope that you all will continue this work as well. So I think, even for our majority, white colleagues, that these are the conversations that sometimes will get a little uncomfortable, but that means you're moving in the right direction. That means we're moving into a space of growth. Growing pains are called growing pains for a reason. That actually means you are stretching, moving, expanding your horizons, right? Beyond your, established bumpers. So that's what we want to encourage everyone to do.
Thank you.
Oh, we can't hear you, Dr.
I think you might be muted, or Dr. Gimenez, I think you're muted. Oh, okay, we can't hear you. Sorry. Oh no, we still can't hear her. Allie, do you want to go now and maybe Cecilia can call in or something?
I think maybe I'll work on, yes, I'll go to my question, and then Dr. Jimenez, do you want?
Oh,
yes, now I can hear you. Great. Thank you.
Beautiful. Good afternoon, Dr. Mason. Thank you for coming. Those in the ACDI committee heard you speak recently in the training session. One of the things that you said was, let's start by learning. And this really resonated. How do you approach the task of teaching about the work that you do? And for us, committed to this work, which method do you find more successful?
Well, thank you for that. I think at my core, I'm an educator at heart. And I think that also allowed me to transition from surgeon to almost a pathfinder educator in the field of orthopedics, which led to this DEI work before it was like DEI work, right? And I find that our path to becoming a physician, particularly in medical education, is a framework that many of us are, number one, accustomed to, but one that we can replicate. And so we're taking an approach in a DEI initiative that we're building at the ACGME called Equity Matters. We're taking a 4-phased approach that starts with education in DEI as we work to build out this, once again, this continuous learning and process improvement adventure. And so at the core, at the very outset of this initiative, we have the acknowledgement phase, which is based on building a fundamental understanding of the concepts, content, and core issues relevant to DE&I. I call it the basic sciences. So we all know we don't move into the clinical setting until we've had our basic sciences. So what are the basic sciences from our perspective? That is, number one, the creation and building an understanding of the importance of having safe and courageous spaces in order to do this work. So once that's creating that inclusive environment and making sure we're treating each other with respect and valuing each other's comments, and using a curiosity approach, in addition to a trauma mitigation, trauma-free approach, understanding that even talking about some of these topics can be traumatizing for people in our environment. So being respectful and aware of that. So that's a fundamental course, right? So it's just a fundamental approach. And then understanding, as we were just going through a couple of the data points earlier around, gender and race and ethnicity, there are at least 20 plus subdomains of diversity where people can identify differently according to not just their gender, their sexual orientation, their race, ethnicity, social economic status, geographic location, country of origin, language preference, like we could go on. So understanding the composition of who's in our work environments, in our medical education environments is critical. Many people do not have that core understanding of who we are dealing with, and building the fundamental knowledge of these concepts also helps us when it comes to an intersectional approach, right? So, we're women, but we are women of color, right? And of different races and ethnicities. And then how does that interplay into who we are and how we're treated in the workplace? And then also, Dr. Gimenez, the fundamentals of data, understanding the metrics and the data points around what exists, and once again establishing the fact that when we are looking at diversity, or because we haven't looked through a lens of diversity, equity, and inclusion in the past, that now we're faced with a set of disparities and inequities, both in education and in healthcare. So we have to take an honest look at the numbers of what we're dealing with and why, in the historical context that brought us here. So that educational approach for me starts with why, and that's not my concept. That's from Simon Sinek, who's a leadership guru in the universe, who has a very nice book and a quick 20-minute YouTube talk on Start With Why. And we have to, I believe that when we then understand the basic sciences, we understand why we're doing this work, then we can move into bias response training, anti-racism, anti-sexism training, how to build a holistic curriculum, how to even build an office of DEI, because you understand why it's needed. When we jump to some of the interventions early on, they fall flat, they're not sustainable, we don't see change because we're not building it on a foundation that's solid, right? So that solid foundation, those are the basic sciences that we are promoting, in our Equity Matters platform. That's the acknowledgement phase. And then once then you have to be accountable and build the tools in order to affect change. So that is kind of the continuum of how we see the educational process in this work going, which once again, just from that, you can see that's a lot, right? So this is a marathon approach, not a sprint. But what we don't want people to do is jump all the way over to let's do some implicit bias training when we're not even real clear what implicit bias is, what is explicit bias, what is bias, why am I even here, right? And so we have to create that context for people, and then we can start layering on the tools and the skills necessary to effectuate change as opposed to jumping ahead. So maybe that's more than you wanted to know, Dr. Gimenez, but those are my thoughts.
Thank you so much.
Thank you.
That was wonderful. Thank you, Dr. Mason. So you work quite a bit in the space of improving the experience of resident physicians and other trainees like fellows especially those underrepresented in medicine. So we are really interested in how you're going about this work as it relates to those of us who work with trainees. So can you talk about this experience and maybe some of the common adverse experiences that you note with trainees as well?
That's another loaded question, Dr. Lowe. Thank you. In my work with Dr. McDade, who's the Chief of Diversity, Equity, and Inclusion at ACGME, we are taking that very approach to the work we're doing, in that we're not just focusing on diversifying the physician workforce. That is our paramount interest, but secondarily, in an effort that everyone can participate in, honestly must participate in, is creating that learning environment that is safe, inclusive, and equitable. And so for us as individual faculty members, as co-residents, as program directors of fellowships and individual programs, all the way up through chairs, GME leadership, and through our institutional leadership, we're taking a reverse ideation approach to say, for our decision makers, those who set policy, those who dictate practices that ultimately influence our culture, from a top-down perspective, what are we doing to create safe, inclusive, and equitable learning environments for all those who are involved, right? That most definitely will work to support our diverse learners, someone who's the first, the only, or different from any number of those 20 subdivisions of diversity would certainly benefit. But if we think about it, if we have a learning environment that is safe, that is inclusive of everyone, where everyone is getting their needs met, then that's the rising tide that lifts all boats. So this is not an effort that is disproportionately beneficial to one group or another. This is the environment that will yield a physician workforce that feels more supported, that is safer to do, to be and express, individually who individuals need to be, but collectively, then we can all begin to benefit from this very healthy work environment. Because it's my personal belief that if we don't have physician safety, we can't have patient safety, right? So in all of the quality and safety work that we're seeking that we've been doing and that we've been seeking to establish from a patient perspective, we have to establish that within the physician, within the health care workplace, in addition to just concentrating on the patient. So, and I believe that precedes that. So I think this is the work that we can do as leaders in our respective departments and in our institutions, to look around the table and say, is everyone represented here? The decisions that we're making today, how would these benefit, or who would be put at risk by the decisions that we're making? What additional input do we need to seek before we make this policy change? Because there might be some negative implications that we're not even thinking about because we haven't asked everyone. So, I think those are some of the inclusive mindset approaches that we can take as leaders just from the very start. And then I think we also have to use our voice more when it comes to creating those environments that are safe and equitable. I'd like to share the story of my chief of orthopedics, Dr. Richard Grant, who was a huge proponent of making sure we always have women in our orthopedic surgery residency program. And from the very beginning, we're talking about culture, right? We're talking about an environment and talking about a positive effect that we can have. On the very first day of my orientation in residency, we're all there in a room, meeting all the attendings, and all the residents are there. And, Dr. Grant is giving his spiel about, from his chief's perspective. And he says also, and by the way, we have women in this program, if you didn't notice, and we will always have women in this program. And because we will always have women, we will not have sexual harassment in this program. Anyone who wants to sexually harass someone will have to come and sexually harass me first. Am I clear? There was that bred a lot of clarity, right?
Yeah,
Everyone was
yeah, definitely.
right.
The leadership sets the tone for sure.
Leadership set the tone and the culture. And immediately for me, I felt safer. That was one less thing. As one of the 2 women residents in that program, I just instantly felt safe. There's one less thing I was going to have to worry about. And that I could then show up and concentrate on what I was there to learn, because I didn't have to worry about fending off any unwarranted advances, right? Because the tone, the culture had been established. And I think we overlook our voice as a tool that can be used in those very same, even if it's on rounds, we can establish what we're doing on rounds. If you're in my rounds group, if I'm a resident, fellow, or an attending, right? That's something that we can all do on an everyday basis. And then if we're doing that, we're modeling the behavior that we want our residents to model as they matriculate through training and into practice. And then they will model that for another group that they have to influence. I think those are the types of things that we can do to help shift the environment. And certainly Dr. Grant was Dr. Grant was African-American. I trained at Howard University. Some people always also ask, well, what can I do if I'm white and you're Black, right? How can I be an ally? How can I help to set a tone as well? Well, I did my general surgery internship at UCLA, and I had a patient. We were rounding, and we got to a patient's door, and the patient said, "I don't want that Black doctor to see me. I don't want her to see me." He was referring to me. And I'm on a team. I'm the only Black person on the team. And the fellow, he was on my urology rotation, and he was a fellow. The fellow, tall, white male, said to the patient, "Sir, Dr. Simpson that's my maiden name. Dr. Simpson is your physician, and she renders excellent healthcare. She's here to take care of you, as are we, but she's a part of our team. And if you don't want her to care for you, you can seek your healthcare somewhere else."
Good.
Once again, setting the tone for the team and set a place of psychological safety for me. I had no idea what he would say. All I knew is that at that moment, I felt marginalized. At that moment, I felt excluded by this patient, not because of what I knew and the excellent care that I could give, but because how I appeared. And that fellow's words reversed that. So then there was a sense of inclusion, the psychological safety. It was actually a provision of resources according to need. I needed to know that my team had my back at that time. And he set the tone for that amongst those team members and for me. And I was able to go through that experience. Certainly, I still remember it all these years later, but it's certainly less traumatizing than the opposite experience, where I've had many residents say that their attendings ask them to stay outside the room while we go in and see the patient. So they're excluded, number one, from the team. Number two, they're missing out on the learning opportunity. And number three, they're being traumatized. Okay. So we have to recognize when we don't use our voice, we are imbuing that environment with a culture and saying that, we don't have to be inclusive here. We can exclude you, and your value is not that of the others. And maybe it's because we don't want confrontation. Maybe we don't want to have this critical conversation with the patient. But I understand that. Using your voice leaves us vulnerable. But think about now the person who was left outside of the room. And many times these types of things are not even addressed later, which they also can be. So let's say you made that decision, went in to see the patient. You can still circle back later with the team and say, guys, upon further thought, I should not have excluded you from that learning experience as the attending. I should have said something differently at the time, now that I've thought about it. Because now what that is saying to our residents and fellows is that I'm human. This is scary to me too. I hate that I put you in that position. I regret it. Can we see if we can do that better? Can we role play that again for the team to see what we could do and how we could handle that situation differently. As physicians and in medical education, we haven't really allowed ourselves to broach that level of authenticity and vulnerability. And that's what I would like to encourage everybody to do, because this subject is like it's the hardest set of topics to discuss. Nobody wants to talk about this, but we have to if we're going to move forward.
Thank you, Dr. Mason, so much for sharing those very poignant and personal examples. But I think it really does resonate to show how much even just one sentence or one phrase, right, like one action of support can really bring up a whole team and establish a more appropriate baseline for a community. So thank you for that sharing.
And yeah, that was wonderful. And another thing that you said was about authenticity and vulnerability and educating. And I think about a lot as an educator in medicine, how educators, like the people who train or teach my elementary age children, have more training in how to educate someone than I do. It's not something that we talk about in medicine. We just assume folks know how to teach, how to lead by example. And obviously not everyone does. And it's a really hard thing to do sometimes. And I think we're all trying to do better every day. But I had a question for you about inclusion. Basically, I think that things in any place where power is held by one group of people, they're never going to change until the people who hold the power look like the population, especially from a diversity, but also from an inclusion perspective. And when you look at pathology, they, compared to other non-surgical subspecialties, we're a relatively diverse workforce, but not compared to the US population. For sure, we're not doing that work. So I was just wondering if you could expand upon what work you think is being done to increase diversity, but also retention and that kind of thing in this area. Like, who's doing a really good job, and how can we all do better? I mean, are there success stories that we can sort of model our behavior after in this area?
There's so many people who've been doing recruitment and retention work for a long time, more so recruitment. Mm-hmm. And I think we're now starting to shift towards a lens of retention, because maybe the reverse of your question first, Dr. Banet, is although we recognize and we see that we're seeing some diversity across some specialties, everyone could do better, right? Especially when it comes to our racial ethnic diversity makeup, in creating environments where those who have a gender identity or sexual orientation that that meets one of our newer categorizations, where they feel included enough and safe enough to share that and be who they are. We could all do better across all of the subdomains of diversity. We do know that if you are Black, trainee, you have at least a 3 to 4 times greater chance of being dismissed on average across all specialties in the US. So when you ask who's doing well, I'm seeing it as a glass half empty approach, because I don't think we know how poorly we are doing. If we have Black and brown residents who make up single percentage points of all residents in the country, we should not have a multi-fold overrepresentation of these residents being dismissed. So that's number one. Number two, I think that in terms of recruitment, if we're starting from, even a K through 12 and then going through an undergraduate approach, the AAMC has been doing this work for a long time. And they have a plethora of resources that we are just awakening to at the ACGME level. Our office is only 2 years old. The AAMC has been doing diversity, equity, and inclusion work, I think, for a couple of decades now. And there are a plethora of resources there when it comes to support, some curricula, and resources around the work that needs to be done. Certainly that's at the UME level, but we can extrapolate that for now to the GME level as we work to build out our own set of GME specific resources. There are organizations, I believe I received some information from the American Academy of Ophthalmology last week. They have a toolkit for residents and program directors around DE&I. I know the American Academy of Orthopedic Surgery has been working with interventions, kind of the origin of my evolution and our pathway program for over 10 years now. And so that work continues in terms of like boots on the ground, actual movement, in terms of physical recruitment of residents into orthopedics. And Interventions has worked with the American College of Radiology in the past, now with the American Academy of Dermatology. So from an organized medicine perspective, there are several associations and organizations that are, now investing resources into this work, because that's what it takes. It's not enough for us to continue to pay lip service to it, but to partner in doing this work once again, to make sure that the actual numbers change in terms of recruitment. I think it's my aspirational dream to build out a set of supportive resources. And that's what we're working on in Equity Matters, to help faculty develop into the educators that we need in order to support and resource everyone in GME to improve that retention. Because I don't think we recognize, like you said, just very eloquently, Dr. Banet, just because we're knowledgeable doesn't mean we know how to transfer that knowledge in a way that benefits all those who come under our umbrella in order to teach. I mean, once we match our residents, there's not a lot of differentiation there that we honor and that we know how to make adjustments to. And I think that's where we have a huge I won't say gap, I'll say opportunity to learn and grow and evolve, right? And being open to being willing to do that and recognizing that just because I know cytopathology doesn't mean I know how to teach that to a myriad of learners who have who come to the table, at different levels for any number of reasons that we won't judge. But because we want everyone to be successful, if I'm the educator, then I get to make the adjustment versus saying, oh, this person isn't a good fit. Maybe they shouldn't have chosen this specialty. Maybe they need to choose another specialty. And we see that so often because of our lack of flexibility and willingness to grow as educators.
In my head, I call that educational empathy, because I think it's a skill that you have to be able to basically rewind your brain and say, let me pretend I'm a PGY1. And this is my second day at a microscope. How did it feel? What did it feel like? Don't start in the middle or at the end, because you'll just lose everyone. But it's a constant battle. It's a constant battle.
Constant. The educational empathy, taking it back to your basic sciences, right? To day one, right? So I tend to just hinge on that model because we all get that. We get how helpless we felt that first day of medical school, or the first day in the new class or on the new rotation. So I think as long as we can continue to go back there, and it doesn't help that we're all overworked, we're exhausted, we're all managing, these syndemics as well. So that empathy lens, I think we have to be a little bit more conscientious and intentional about exercising empathy. Because what we have to understand, and especially in DEI work, that your intent is not what creates the outcome, it's the action, right? So even though I didn't intend to step on your foot, it's still painful to that person. I may not have intended to address you incorrectly or to abbreviate your name or not take the time to learn how to say your name. But if I truncate your name because I don't want to take the time to adapt to learn it, then that person could feel excluded versus me saying, could you help me practice saying your name? I just want to be respectful and I want to be able to enunciate it. Even if I get it wrong the first couple of times, feel free to correct me. We don't give ourselves those types of permissions to have to adapt as the educators because of the dominant culture of hierarchy and patriarchy that medical education just has followed as, that's the crux of how we're educated. So don't get me started on that, Dr. Banet. We'll be here another hour.
You can come back. It'll be like a therapy session for me, I promise.
So, Dr. Mason, with your work with intervention, I know it's your mission to work with young people, helping them decide on their path in life. And so can you talk about what it is to have successful mentorship and what that would look like, and how do programs that have this, what do they have in common?
We built Interventions on the foundation of mentorship because I had the most phenomenal mentors, starting with my mom, who was she was a construction engineer in the 70s in Atlanta, in post-civil rights Atlanta. And so she was the only woman in the field, right? And she was the boss, and she was Black. Like, that was a lot. So I don't think I recognized that and I asked her, I said, well, who came before you, Mom? This was just like 2 years ago. And she was like, no one. I said, so Mom, you were the first? She was like, I was like, that means you were the first, lady. You were the first. So just watching her get up and just, over time, recognizing the breadth and depth of what she had to do every day. She's a huge mentor for me. So it didn't dawn on me that I couldn't be an orthopedic surgeon, or that wouldn't work out for me because I watched my mother do it. And then I had male mentors such as Dr. Grant and others in orthopedics that served as mentors for me as well, along with my track coach, Coach William P. Moultrie, prior to matriculating into orthopedics, that set the bar high, but also gave me the tools, told me what I needed to know, and then watched my responsiveness. And for me, how I responded, they would then gauge and then nudge or prod in a different direction. But it was because they saw something in me, or that I could be successful, that sometimes I wasn't sure about, but they would always reinforce that in a very positive way, even if I made a misstep. And I found that to be a consistent set of characteristics in my mentors that I think, if we could all look at ourselves in that way as a mentor, someone who's here to help guide, not lower the bar, but say, this is the bar. You have what it takes to reach it. Let me help and direct you in getting there. That's what successful mentorship looks like. And once again, it's not comfortable. Oh boy, my mentors were tough. Everybody I named they were tough, but not in a mean way, but in a molding way, right? So I think for the programs, to answer your question, Dr. Henderson-Jackson, for programs who are intentional about setting up that mentorship and recognizing that, that we may have a Latina resident, but we don't have any Latina faculty. That doesn't mean that person should not get a faculty mentor, right? That means we want a mentor who's open to mentoring, encouraging, and helping to mold this resident past the finish line, even though they may be of differing backgrounds. So what we do is we encourage them to communicate, spend time, tell each other stories about their families. And what we find is that many times, just in terms of the human condition story and evolution, we have more in common than we know. And when we encourage that communication, that's when that common ground is found, or not. So maybe it doesn't work out between that mentor and mentee in our program. Find another mentor, right? Let's continue to make adjustments and say, okay, that one didn't work out, but that doesn't mean you won't be successful here in this program. Let's continue to make sure that we're actively mentoring you. And I encourage all of my students and residents have way more than one mentor. Don't limit yourself to that one mentor, because one person can mentor, have a mentor from a clinical perspective, from a surgical perspective, from a leadership perspective, from a co-residents. Co-residents can mentor one another. And so I think, using that, once again, that's a teamwork approach to, and it combats the isolation. For me, isolation is kryptonite. So to successful matriculation. So if we are intentional about setting up mentorship programs for our residents with faculty and for our junior faculty with senior faculty, that's another way that we can make sure that we're not just retaining our residents, but we're also retaining faculty over time, so that we can continue that culture nurturing, support, equity, and inclusion that we're looking to build. So I think that mentorship for us in medical education will continue to evolve, should evolve formally as something that most programs who have, done a really good job in DEI and anti-racism, anti-sexism, they've done a really good job of being intentional about those contact and connection points through mentorship.
Okay.
Thank you.
Can you hear me?
Yes.
Okay, good. Have you ever faced a situation where leadership of an institution consider it is diverse enough? And I don't see the lack of actually diversity as a problem. And if so, how you address that situation?
Well, as everyone on this call knows, not everyone agrees that diversity is important, that it requires, resource allocation and human resources to support the work. I had the pleasure in orthopedics prior to coming to the ACGME. I would give grand rounds across the country in departments of orthopedics discussing diversity, equity, and inclusion. So you can imagine how much fun that was. And I had to reconcile that very question. Like, I might be the only one in this room that looks like me, much less from a leadership perspective, but in terms of the audience itself. And we have to take a stepwise approach, Dr. Gimenez. We're not going to change everyone's mind, and nor should we expect to. I think what we have the opportunity to do is to continue the conversation, to continue to be open to answering questions, the hard questions, and then encouraging others to ask themselves the hard questions. Am I willing to, let's just say, take the Harvard Implicit Association test, even if it may reveal to me some biases that I may or may not have known I had? And am I willing to address the biases that are revealed? That's even where we've started with our leadership at ACGME, asking them to, reflect first. And then and many times connecting that with our humanity to say, we're nice people, but we can still have biases, and we all do. And then letting everyone off the hook to say we're all still learning in this space as well. Those are the steps that I've found myself taking with people who may or may not agree, understand, or wish to know, but also connecting it with my humanity with theirs. That's where a lot of the work comes in. And it can be, it can be draining. But then you get to, you see, so what I find at the end of those grand rounds is, many times they say, okay, any questions? No questions, complete silence. So I'm like, oh, okay. And then the chair would ask the obligatory question, chair's question, and we would end. But at the end of the lecture, almost without fail, sometimes 4 to 5 people would come up and give me their business cards to say, if I can be of support, I want to learn more. Let me know how we can stay in touch. And so that's letting me know, like with this little trickle effect, that, people are at least now more open and willing to consider, think about, and perseverate over some issues that they may not have even wanted to discuss before. At least some people are open. So I think that's the marathon approach that I was mentioning earlier. Mm-hmm. That's it. Yeah.
Thank you.
Thank you.
Yeah, no, that's great. I definitely think it is a long-term, big picture, underlying dominant culture issue that no single person is responsible for. And I think that is where a lot of the difficulty comes in, when people feel like, I'm not a bad person. And I don't think many people are bad people. I think it's not ill-intentioned. And I think it is more just like recognizing the current that we are living in and don't even realize we're getting pushed off to this side. And a current exists. So I think conversations like this are so great to just help people even get a little bit of exposure to possibly what may be more broadly out there. I know we're getting close to the hour, and I would like to see if there's any parting thoughts you have that you just want to share that we haven't covered, and then maybe we'll do a few ending polling questions and get to a few audience questions there. Okay. So any other thoughts that you have for us?
No, I think, I will keep talking if you let me. So no, I think I'm pretty much done for now. I'm happy to, let's see what audience questions we may have. But once again, team, I really appreciate being here today and the invitation and the engagement to have this opportunity to engage around this important set of subjects. So we have a lot more work to do, but I thoroughly believe that we can be successful together and that we shouldn't try to do this alone. So.
Great. Thank you so much, Dr. Mason. Yeah, so I'll encourage people to put more questions in the chat if they have any. We'll get to one right now that I think is relevant that, Beth, if you could bring up our first additional supplemental slide, I think it can answer the question pretty nicely. The question is, how does the distribution of racial identity among U.S. medical students compare to what we showed for pathology and cytopathology? And so if you go down to the Marissa White figure 7, there's a yellow and blue, a yellow and blue figure. Let's see, try 2 more, maybe. Yes, this one right here. Sorry, go back. Yes, right here. So here we can see that there is the U.S. Census distribution for Hispanic, Black, and then other underrepresented minorities at the very top line. And the question is focused on kind of trainees and how we're doing in trainees, but this is pathology-specific data that Dr. White, who is a great leader in this field within pathology, has published recently that shows how the distribution of medical school graduates compares to the U.S. Census, and then beyond that, the applicants to pathology compared to the total GME pool, how many pathology residents actually matriculate from these diverse backgrounds, and then moving on to fellows, then practicing pathologists. And you can see there's actually some drop there when we get to the practicing component and then pathology faculty. So I thought this was a very informative image, and we'll have these posted associated with the presentation later on and some other figures from the paper as well, just to give us a sense of how we in pathology are doing. So this is a snapshot from a few years ago, and I think it is just a work in progress. I don't think there's been that much. I don't know if there are significant differences, you think, Dr. Mason, between our subspecialty and other subspecialties with regard to this breakdown in significant drop, I guess I would say population-wise versus other trainees.
This is pretty much consistent with what we're seeing that, right around that for Hispanic and Latino residents, right around that 5 or 6% representation, and usually a percentage point or 2 less when it comes to African Americans in particular specialties, just kind of overall. So that's what we're seeing as well across specialties.
Great. Yeah, thank you. Well, I know we're going a little over, so why don't we switch to our closing polling questions, and then if there are any other questions that folks have, if they want to stay on afterwards, then we can continue the conversation then. All right, so before we close our time together, our first closing polling question that we have for you is super basic. It is, I gain knowledge about DEI, diversity, equity, and inclusion from this talk. I'm hopeful that some of you did, but if you didn't, that is perfectly fine too. I will not be offended in any way. But yes, appreciate just hearing your thoughts on this. And thank you for all of you being so generous and agreeing. I appreciate that very much. And then our second closing polling question for you is, do you have access to resources to support you in furthering DEI in your areas of influence. Thank you so much for those who have contributed. And I'm so glad to see that people feel that they do. And it is hard to see that some other people feel that they don't, but that's very real. And I, again, would just like to expound upon the fact that I know we are just a YouTube video, but we are actually people. There are people behind this, people who are very passionate and care about these things within the cytology, but beyond cytology as well. And so you definitely can reach out to any one of us. For now, we're just filtering it through the general cytology email, but always open to conversations or finding ways to support you in any way. Dr. Mason is very connected with resources. I continue to pick her brain for all the different resources that are out there, but many of them are a little bit grassroots in some ways, where there are really just only a few people in a certain organization, or even a single person in an organization who feels passionate about this. And it is hard to find support in that small sphere, but there is a huge body of support and care that does exist. And we need to find ways to connect us all. And honestly, in this new COVID world, we've been able to connect pretty well, actually, much more easily than before. So if there are ways that you would like to find other support, please do reach out to us at asc@cytopathology.org, and we can definitely get you tuned into that. So I'm going to officially close the session for now. And I don't think there are any burning questions here, it seems. So if anyone else has additional closing thoughts, we'll leave it at that. But again, thank you so much for joining us today, Dr. Mason.
I'd like to thank all of you very much.
Yes, absolutely. Thank
Dr.
you.
Mason and our wonderful DEI committee. This was a fabulous session. Thank you all very much for your time and all your thoughts. This was a great session. I'm sure everybody learned from this. I did. And see you all. Be well.
Thank you.
Thank you, Dr. Mason. Bye-bye.
Thank you.